Welcome to online anesthesia video of the week. Today topic is presented by Dr. Maheshwari S Kumar, a consultant anesthesiologist in Ganga Hospital, Coimbatore. After completing DA in Ramachandra Medical College, she had joined as junior registrar in Ganga Hospital in 1999. Then did DNB in Ganga Hospital itself and continuing to work there for the past 25 years.
Good morning. Dr. Maheshwari, consultant anesthesiologist, Ganga Hospital. At first, I'd like to thank the organizers for giving me this opportunity to be part of this program. In today's topic, we'll discuss PNS guided above and below clavicle blocks. As you all know, brachial plexus, it arises from the anterior primary rami of C5 to T1. And these 5 roots converge together to form 3 trunks, the upper, middle, and the lower trunk. Each of these trunks divide into anterior and posterior divisions. The anterior division of the upper and the middle trunk join together to form the lateral cord. The anterior division of the inferior trunk forms the medial cord, and the posterior division of the upper, middle, and the inferior trunk forms the posterior cord. These 3 cords finally give the terminal 5 branches: the ulna, median, radial, axillary, and the musculocutaneous. The brachial plexus block, they are named according to the approaches are named according to where the drug is deposited. When the drug is deposited at the level of trunks, it is called interscalene. At the level of divisions, it is called supraclavicular, subclavian, perivascular. At the level of cords, it is called infraclavicular, and at the level of terminal branches, it is called as axillary. Now, coming to the above clavicle blocks, there are 2 types: the interscalene block, which is done at the level of trunks, and the subclavian perivascular block, which is done at the level of divisions. Seeing the anatomy for the interscalene block, the 5 roots, they converge together to form the 3 trunks, the upper, middle, and the lower trunk. And these 3 trunks run in the neck between the anterior and middle scalene muscles, and they run laterally and posteriorly over the first rib to enter into the axilla. In this anatomical dissection diagram, we can see the upper, middle, and the lower trunk running in the neck between the middle and the anterior scalene muscles, and they run laterally and posteriorly, and they cross over the first rib to enter into the axilla. Now, coming to the approaches, when we do the above clavicle brachial plexus block, in the interscalene approach, we have the Winnie's approach, which is the most commonly followed approach. And for the subclavian perivascular, we have the Winnie's approach and the Blum-Bob approach. The interscalene block, it is indicated for open shoulder surgeries and arthroscopic procedures, fracture proximal humerus, lateral 2/3 of clavicle fracture. It is also used for the treatment of adhesive shoulder capsulitis, frozen shoulder, hepatic neuralgia, and creation of arteriovenous fistula. The contraindications, absolute contraindications, are patient's refusal, local infection, allergy to local anesthetic. The relative contraindications are chronic obstructive airway disease, contralateral paresis of the phrenic, previous neurological deficit of the involved arm. Before we do the interscalene block, with the help of a skin marker, we can mark the anatomy. The patient's head is turned to the opposite side where the side of the block to be given. Then we mark C6 level, which is the cricoid cartilage just above the sternal notch. Then ask the patient to raise the head, and we'll make the sternocleidomastoid more prominent. Mark the sternal head and the clavicular head. The interscalene groove lies 1 centimeter lateral to the lateral end of the clavicular head of the sternocleidomastoid. When we do the interscalene block, the best motor response which we look for should be involved in the muscles of pectoralis, deltoid, triceps, biceps, or any twitch of the hand or forearm. If we have 2 or 3 muscle involvements, then the end motor response is good and the block would be very effective. In this video, I will tell you how we do the interscalene block. Turn the patient's head to the opposite side of which we are going to give the block. And if you see, he has a very good anatomy. You raise the head of the patient and make the sternocleidomastoid muscle very prominent. You can see the sternal head and the clavicular head. Now palpate the center of his neck. And first what we palpate will be the thyroid. And then below that, we will be palpating the cricoid at C6. Now move the finger laterally and the finger will dip between the 2 heads of the sternocleidomastoid. Do not get confused with this because this is not the interscalene groove. Move more laterally and we will feel the lateral end of the clavicular head of the sternocleidomastoid. From that point, take 1 centimeter lateral and our finger will dip between the scalenus anterior and scalenus medius muscle. This is the interscalene groove. Now keep your thumb and in the interscalene groove and at the apex. So what we are feeling now is the apex of the interscalene groove. Now we need to fix this thumb because the skin in this area is very labile and it will move. So fix the thumb and at this point of entry, you take the needle and insert it close to the thumb at the midpoint of your thumb and imagine that the tip of the needle is facing the ipsilateral nipple and you look for the end motor response. Here we are getting a single biceps twitch, so we are not accepting that. We are now, if you see, once the needle is inserted little further down, you are getting pectoralis major and triceps, which is an extension of the arm. So this end motor response is accepted, the current is reduced, and the drug is injected at 0.5 milliamperes of current. Coming to the complications, an interscalene block is phrenic nerve paresis, neurological injury, central neural blockade, Horner syndrome, recurrent laryngeal nerve palsy, pneumothorax, and auditory complications. Now the second above clavicle block is the subclavian perivascular block. This block is performed where the brachial plexus is presented most compactly at the distal trunk level. This block is called the spinal anesthesia of the upper limb. It is indicated in all surgeries, including the humerus and elbow, forearm, and hand. It is used for a closed reduction or for the elbow dislocation. Contraindications are severe COPD, contralateral pneumothorax, and local site infection. The technique in which the subclavian perivascular block is done is we have 2 approaches, as I had earlier mentioned. One is the Winnie's approach and the other is the plumb-bob approach. The Winnie's approach, the needle is inserted 2 centimeters posterior to the midpoint of the clavicle, parallel to the neck, towards the ipsilateral nipple. The plumb-bob approach, the needle entry is immediately superior to the clavicle, just lateral to the point where the sternocleidomastoid inserts on the clavicle. And here the entry of the needle is at 90 degrees to the skin. So in this slide, you can see the landmarks for the subclavian perivascular block and the point of needle insertion. We first mark the clavicle and then the 2 ends of the heads of the sternocleidomastoid are marked and then the interscalene triangle is taken and you can mark the point A is the base of the triangle and point C is the apex of the triangle. The interscalene block is given at the apex, whereas the subclavian perivascular block is given at the base of the interscalene triangle. So in this slide, I will tell you how exactly we do the subclavian perivascular block. This man is an 80-year-old man with chronic renal failure who came with distal radius fracture. So with the marker pen, we have marked the two ends of the sternocleidomastoid. And what I'm palpating is the lower part of at the base of the interscalene groove, we are palpating the subclavian artery against the clavicle. So once you palpate and fix the subclavian artery, you take the needle and the midpoint of your thumb has to be the point of entry, and imagine that the needle has to go posterolateral to the point of insertion of the artery. And once the needle is inserted, you get the end motor response. And here you will see extension of the arm, which is the posterior cord response and which is the best response. You accept this response, reduce the current, and we inject the drug. Now coming to how do you do it? The position is similar to interscalene. And the only problem is we have to remember while doing the subclavian perivascular, if we get only biceps contraction, then that means the needle is too lateral. And if we get only pectoralis major, then the needle is too anterior. And if we get a scapular movement, then the needle is too posterior. So the best end motor response which we should get will be the posterior cord response, which is the extension of the hand or the finger movements, which will be our best end motor response. When we do this block, the intercostal brachial nerve is spared because it arises from T2 and it carries a cutaneous sensation from the inner aspect of the arm. And this is not covered by the block, but here we can infiltrate local anesthetic along the nerve bar and it will be covered. The lower trunk of the brachial plexus is also spared. The ulnar nerve of the lower trunk is frequently missed in this as it lies under the artery. Coming to the complications is phrenic nerve palsy, pneumothorax, intravascular injection, hematoma, Horner syndrome, and neurological injury. Now, the take-home message for this above clavicular block is identifying the interscalene groove is very, very important. It is 1 centimeter lateral to the clavicular head of the sternocleidomastoid at the level of C6. And in this, even if the cast or splint is there, we need not have to be worried. As long as the fingers are visible, it is sufficient. And the needle should be inserted lateral to sternocleidomastoid insertion. It should not be inserted more than 1 inch if your plexus is not found. And we should remember that carotid vertebral artery, subclavian artery, the transcervical artery are the primary vascular punctures sites risks during this interscalene and subclavian perivascular approach. So always we need to remember to aspirate before we inject the drug. And stimulation of the middle trunk indicated by hand contraction has been associated with higher success rates for the hand surgery. Now coming to below clavicle blocks, there are 2 types. One is the infraclavicular, which is given at the level of cords, and the other is the axillary, which is given at the level of the terminal branches. The infraclavicular block, it provides a block of the arm below the shoulder, and unlike the axillary approach, it can be performed without abduction of the arm, making it useful for patients with limited shoulder mobility. Coming to the anatomy for this infraclavicular block, the anterior division of the upper and middle trunk C5, C6, C7 unite to form the lateral cord and which lies lateral to the axillary artery. The posterior cord is formed by all the posterior divisions of C5 to T1 and lies posterior to the artery just under the lateral cord. The anterior division of the lower trunk C8 and T1 unite to form the medial cord and it lies medial to the axillary artery. So the infraclavicular block, the cords are blocked in relation, they lie in relation to the axillary artery. So in this picture, we can see that the lateral cord is the most superficial, then lies the posterior cord, and the medial cord is the deepest to the axillary artery. The functional anatomy of the brachial plexus in the infraclavicular region is very complex and it is very variable. So the lateral cord is the most superficial and the posterior cord is next and the medial cord is the deepest. The lateral cord and the medial cord each contain half of the median nerve. The posterior cord contains all of the radial nerve. The musculocutaneous nerve is often lies outside but very close to the lateral cord. The medial cord contains ulna and the median nerve. Now, how to do the infraclavicular block? Coming to the approaches, various approaches were described. The vertical infraclavicular block by Kilka and colleagues, then the modified Raj approach, the lateral and sagittal approach by Catstick. Wiffler described the coracoid approach, and this coracoid approach is the one which is most commonly used in all organizations. Coming to this coracoid technique, how do we do it? In this coracoid technique, there were 4 different people described it in 4 different ways. But Wilson was the only one who, with the help of an MRI, told us that we have to go 2 centimeters inferior and 2 centimeters medial to the coracoid process. So we take the coracoid process as the bony landmark and go 2 centimeters medial and 2 centimeters inferior is the point of entry. This infraclavicular block is used for all surgeries of upper arm, elbow, forearm, and hand, and it is an excellent choice for patients with respiratory diseases like COPD. And in case we want to give bilateral blocks, this is the best approach. Patients who have restricted shoulder abduction, and it is a preferred approach to place continuous catheters. There are no block-specific contraindications to infraclavicular block except infection, and coagulopathy is a relative contraindication based on the risk-benefit ratio. Now let us just briefly see the end motor responses which we will observe when we stimulate the cords. The lateral cord contains the musculocutaneous and the median nerve, and when we stimulate musculocutaneous, you get flexion of the elbow, and median nerve, we get flexion of fingers and opposition of the thumb. When we stimulate the posterior cord, which has radial and the axillary, in the radial nerve, we get abduction of thumb and extension of fingers and wrist, and in the axillary nerve stimulation, you get elevation of the upper arm. Coming to the median cord, which contains the ulna and the median nerve, when you stimulate the ulnar nerve, you get contraction of 4th and 5th finger, abduction of the thumb. And the median nerve, flexion of the first 3.5 fingers and opposition of the thumb. The most important landmark when we do the infraclavicular block is the coracoid process. So, how do you feel for this coracoid process? So, what we are supposed to do when the patient is lying supine, with one of our hands, we palpate below the clavicle and keep moving from the medial to the lateral side towards the shoulder. And with our other hand, bring the shoulder of the patient closer to you. As the shoulder is brought closer to the body and your finger is palpating below the clavicle, moving from medial to the lateral end, the first bony prominence which we will come in contact with will be the coracoid process. This coracoid process is marked with a skin marker and the point of entry is taken 2 centimeters medial, 2 centimeters inferior to this point. Now in this slide, you see the landmarks have been marked, the skin pen, and you can see the deltopectoral groove. Now what is this deltopectoral groove? So what we do is, to make things simpler, we take the 2 ends of the clavicle and draw a line joining both the ends of the clavicle. Then feel for the axillary artery pulsation in the axilla. The highest part of the axillary artery pulsation is taken and a line is drawn from there to intersect the line joining both ends of the clavicle. This is called the deltopectoral groove. Then we palpate below the clavicle, and as we move laterally and the we identify the coracoid process, and from this coracoid process, when you take 2 centimeters medial and 2 centimeters inferior, that point of entry will invariably fall in this deltopectoral groove, and this helps us to make the point of entry safe so that we do not move very medially. When we do the infraclavicular block, the most desirable response which we require is the elbow flexion with radial deviation of the wrist, which represents stimulation of the brachioradialis muscle and a posterior cord response. So the goal has to be, when we get a lateral cord response, we should avoid injecting the drug. If we get a medial cord response, then it is okay to inject, but the best will be the posterior cord response, which is the radial block. And that is the ideal response which we should get. Either we can get flexion or extension of the fingers, but extension is the best. In this slide, I will tell you how we do the infraclavicular block. And if you see, the coracoid process is identified, and 2 centimeters medial and 2 centimeters inferior is a point of entry is taken, and the needle is inserted at 90 degrees at around 1 to 2 centimeters down, and you get the end motor response. We set the current at around 1 to 1.5 milliamperes, and we look for the contractions. And here you can see the distal contractions where once the needle is inserted, the finger movements or extension of the hands and the fingers are there. This is the posterior cord response. Immediately the current is reduced and the drug is injected. Now coming to the next below clavicle block is the axillary brachial plexus block. The anatomy of the axilla, the median ulna and the radial nerve accompany their blood vessels through the ulna, through the axilla, where the blocks are performed. While the axillary and musculocutaneous nerves leave the plexus approximately at the level of coracoid process, the musculocutaneous nerve lies outside the sheath. In the axilla, the median and the musculocutaneous nerve lie superior to the artery, whereas the ulna and the radial nerve lie inferior to it. And also, the median nerve is more superficial than the musculocutaneous, and the ulnar nerve is more superficial than the radial nerve. So in this slide, you can see that the ulnar, median, and the radial nerve in relation to the axillary artery. The median nerve lies at 11 o'clock position, and if you see the ulnar nerve at around 3 o'clock and the radial nerve between 5 and 6 o'clock position. Before doing the block, the landmarks which are very important is you keep the patient supine and the hand abducted, and the axillary artery pulsation is felt. You mark that point, and the next is you feel the muscle above that is the coracobrachialis muscle, and below that is the triceps muscle. So this landmark is very, very important. So you mark the axillary artery, then above that you have the coracobrachialis muscle, and then above that is the biceps. Below the artery, you have the triceps. Now, when we do the block, you have something called the double injection technique. You can go above the artery and below the artery. So first the needle is inserted above the artery, below the just below the coracobrachialis muscle. If you get a median nerve response, which is a wrist pronation, you can inject half of the drug, then remove it and go below the artery. If you get a ulnar nerve stimulation, ignore and go deeper. You will get a radial nerve stimulation, which is the wrist extension or a finger extension. You inject the drug. So here you can see how we do the block. The axillary artery pulsation is felt and the needle is inserted exactly above the artery, below the coracobrachialis muscle, and you can see flexion of the elbow. And this is a stimulation of the musculocutaneous nerve. The current is reduced and the drug is injected. Now, keeping the thumb on the axillary artery, the needle is inserted below the artery, and you can see extension of the fingers, which is a radial nerve response. So reduce the current and you can inject 10 ml of drug below the artery. To conclude, the take-home message for below clavicle blocks is an optimal approach to brachial plexus for several reasons. It has the minimal risk of pneumothorax. Bilateral blocks can be done when it is required. The landmarks are very easily palpable. Even in an obese patient, you can palpate the coracoid process very easily. So you can give an infraclavicular block. And these areas are most ideal for catheter placement. Thank you.